every morning, before breakfast, after breakfast, or sometime around when you remember. You take your blood pressure pill because that is what the label says, once daily. And that means morning. That has always meant morning. Nobody specified otherwise. Nobody explained that the timing of this medication relative to your body's own internal clock could be the difference between protection and danger. But here's what the research published in the last decade has been quietly establishing. For a meaningful percentage of seniors on blood pressure medication, taking the pill in the morning is the most dangerous time to take it. Not because the medication is wrong, because of when their blood pressure is most dangerous and when the medication is therefore most needed. And when, by taking it in the morning, their pressure has already recovered to risky levels by the time the hours most associated with cardiac events arrive. And for a different group of seniors, taking the medication in the evening produces a blood pressure drop during sleep that goes too low, low enough to reduce blood flow to the brain, low enough to be associated with faster cognitive decline, low enough that the medication protecting the heart may be quietly harming the mind. Same medication, same dose. The timing changes everything. I am Dr. Eric Berg, and in the next few minutes, I'm going to explain the science of blood pressure timing, what your body's circadian blood pressure rhythm actually looks like, why it matters more than most physicians communicate, and how to identify which timing is right for your specific pressure pattern. Because there is no universal answer, and that is exactly the problem. Stay with me. Drop 2 things in the comments right now: your age and the city and state where you are watching from. Because this community is being built one person at a time. In Birmingham, Alabama, in Houston, Texas, in Memphis, Tennessee, in Jacksonville, Florida, in every bedroom where someone is reaching for their blood pressure pill at 7 a.m. and has never once been told whether morning is the right time for them specifically. Drop your age and your location right now. And if you currently take your blood pressure medication in the morning, type the word morning in the comments. If you take it in the evening, type evening. Because the distribution of that answer in this community tells me something important about how many people are potentially taking their medication at the wrong time without knowing it. Hit subscribe right now to help this community grow. The next senior starting a blood pressure medication who gets a take once daily instruction without the timing conversation deserves to find this channel. Now, something important about the prescribing landscape. When a physician writes take once daily, they are not being negligent. They are following the standard prescribing convention that has been in place for decades. A convention built primarily on studies conducted in middle-aged adults in daytime clinical settings, measuring morning blood pressure as the primary outcome variable. The research on circadian blood pressure patterns, on what pressure actually does throughout the night, on the specific hours when cardiac and stroke risk are elevated, on the relationship between nighttime blood pressure and organ damage, has accumulated significantly over the past 15 years. And the take once daily instruction has not caught up. The $32 billion blood pressure medication market generates its revenue from the prescription, not from the timing conversation that determines whether the prescription protects you at the right moment. Hit like if you think every American senior on blood pressure medication deserves to know when the right time to take it actually is. Your blood pressure does not stay still, and understanding its pattern changes everything. Most seniors on blood pressure medication think of their blood pressure as a number, the number on the cuff, the number their physician writes in the chart, the number the medication is supposed to lower. What blood pressure actually is a rhythm, a daily cycle. And within that cycle, there are specific windows of danger and specific windows of relative safety that determine when medication coverage matters most. Here's what a healthy blood pressure rhythm looks like over 24 hours. In the morning, typically between 6 a.m. and noon, blood pressure rises steeply. This is driven by the cortisol awakening response, increased sympathetic nervous system activity as the body mobilizes for the day, and the natural surge in catecholamines, adrenaline and noradrenaline, that accompanies waking. By 8 to 10 a.m., blood pressure in most adults is at or near its daily peak. From late morning through mid-afternoon, pressure plateaus and then begins a gradual decline. In the evening and early night, pressure drops further. In healthy adults, the blood pressure during sleep is typically 10 to 20% lower than daytime values. This nighttime dip, the physiological reduction in pressure during sleep, is one of the most important cardiovascular protective mechanisms the body has. It allows the heart, the blood vessels, the kidneys, and the brain to recover from the daytime pressure load. Then, in the early morning hours, typically between 3 and 6 a.m., blood pressure begins rising again before waking. This pre-dawn surge is the most dangerous window in the cardiovascular day. The research is clear and consistent. The majority of heart attacks, strokes, and sudden cardiac deaths occur in the hours between 6 and 10 a.m., the window of the morning blood pressure surge. Now, here's where medication timing becomes critical. A morning dose of most blood pressure medications reaches peak effectiveness approximately 2 to 4 hours after ingestion, depending on the specific drug. If you take Amlodipine or Lisinopril at 7 a.m., peak medication effect arrives between 9 and 11 a.m. The pressure may already be at its daily peak and beginning to decline. The medication is covering a window that may not need the most protection. Meanwhile, in the pre-dawn hours, when pressure is surging and cardiac risk is highest, the morning medication has been metabolizing for 16 to 20 hours. Its effect is at its weakest point of the day. The protection is lowest precisely when the danger is highest. A 2019 landmark study published in the European Heart Journal, the Hygia chronotherapy trial, followed 19,084 adults with hypertension for a median of 6 years. Half took their medication in the morning, half took it at bedtime. The bedtime group had significantly better nighttime blood pressure control, a significantly larger nocturnal dip, and most critically, a 45% lower risk of major cardiovascular events, including heart attack and stroke. 45% lower cardiovascular risk. From moving the pill from morning to bedtime, same medication, same dose, different clock position. The complexity, why it is not simply take it at night, why the answer is not universal, and why that matters for you specifically. The Hygia trial result is compelling, but before you move your medication to bedtime based on a single study, there are 2 critical complications that the 15-minute appointment never explains. The first complication is the non-dipper pattern versus the over-dipper risk. Most healthy adults experience the physiological nighttime blood pressure dip described above, a 10 to 20% reduction in pressure during sleep. These are called dippers. For dippers, the cardiovascular risk is concentrated in the morning surge, and bedtime medication that strengthens the nocturnal dip may be protective. But approximately 25 to 30% of adults and a higher proportion of older adults with established hypertension are non-dippers. Their blood pressure does not fall sufficiently during sleep. Their pressure stays elevated throughout the night. For non-dippers, the nighttime hours are a sustained period of cardiovascular stress, and their organ damage to the kidneys, the heart, and the brain accumulates during sleep. For non-dippers specifically, evening medication that improves the nocturnal dip may produce significant cardiovascular benefit. However, a third group exists that is equally important: over-dippers. These are individuals whose blood pressure drops more than 20% during sleep, sometimes dramatically more. For over-dippers, evening medication that amplifies an already excessive nocturnal dip can reduce nighttime blood pressure to levels that compromise cerebral perfusion, blood flow to the brain. A 2022 study published in Hypertension found that over-dippers with excessively low nighttime blood pressure had significantly higher rates of white matter lesions in the brain. The same findings discussed in the Memory and Brain MRI video, consistent with reduced nighttime cerebral blood flow. In over-dippers, evening medication that drives nighttime pressure even lower may accelerate cognitive decline rather than protect against it. The second complication is the drug-specific half-life. The Hygia trial used a variety of antihypertensive medications. Not all of them behave the same way with timing shifts. Amlodipine, with its 35 to 50-hour half-life in most adults, maintains relatively stable blood concentrations regardless of whether it is taken morning or evening, making timing less critical for this specific medication than for shorter-acting agents. Lisinopril and Losartan, with effective half-lives of 12 hours or less in many patients, show more pronounced timing-dependent effects on the nighttime versus morning pressure coverage pattern. What this means in practice. The timing question is not the same question for a patient on amlodipine alone as it is for a patient on lisinopril twice daily or a patient on a combination regimen. The answer depends on which drug, which patient, and which blood pressure pattern. And determining that requires ambulatory blood pressure monitoring, a 24-hour blood pressure recording that captures the complete circadian pattern, including sleep. How to find your pattern. The tool that identifies your circadian pattern and the conversation that follows. Ambulatory blood pressure monitoring is the clinical gold standard for identifying whether a patient is a dipper, a non-dipper, or an over-dipper. The device, a standard blood pressure cuff attached to a small recorder worn on the belt, measures pressure automatically every 15 to 30 minutes for 24 hours, including during sleep. The resulting profile shows exactly what the pressure is doing at 2 a.m., at 4 a.m., at 6 a.m., and throughout the day. This test is covered under Medicare Part B when ordered by a physician with appropriate clinical documentation. It is performed at most cardiology practices, nephrology clinics, and increasingly through primary care settings in larger cities across America. If you have never had an ambulatory blood pressure monitor, and most seniors on blood pressure medication have not, this is the conversation to initiate at your next appointment. Say these exact words. I would like to understand my circadian blood pressure pattern, whether I am a dipper, non-dipper, or over-dipper, because I understand this determines the optimal timing for my blood pressure medication. Can we order an ambulatory blood pressure monitor? That sentence, specific, clinically precise, clearly framed, will produce a productive response from any physician familiar with the current evidence base on blood pressure chronotherapy. If ambulatory monitoring is not immediately available, a practical approximation can be developed through systematic home blood pressure monitoring with a properly calibrated device. Here is the home protocol for approximating your dipper status. For 5 consecutive nights, check your blood pressure at 3 specific time points. First reading, 30 minutes after your usual waking time. Second reading, 11 p.m. or just before bed. Third reading, 3 to 4 a.m. If you can manage a single waking at that time, either naturally or by setting an alarm for one night to establish baseline. Compare your average 3 to 4 a.m. reading to your average daytime reading. If your nighttime reading is more than 20% below your daytime average, you may be an over-dipper. If your nighttime reading is within 10% of your daytime average, you may be a non-dipper. If it falls between 10 and 20% below, you are likely a dipper. An Omron Series 5 or Series 7 blood pressure monitor available at Walmart, CVS, or Kroger for $35 to $55 is accurate enough for this purpose and is among the most physician-accepted home monitoring devices. Bring your 5-night home log to your appointment alongside the ambulatory monitoring request. Your physician now has a starting data set and a specific clinical question to answer together. 19,084 adults, 6 years of follow-up, 45% lower cardiovascular risk from moving the medication from morning to bedtime in the patients for whom bedtime was the correct timing. And a parallel finding that in overdippers, patients whose nighttime blood pressure already drops too low, evening medication may accelerate the cognitive decline associated with insufficient nighttime cerebral blood flow. Same medication, same dose. The timing determines whether the drug protects you or harms you. And the take once daily instruction on the label gives you no information about which one applies to you. The $32 billion blood pressure medication market generates its revenue from the prescription. The timing conversation, the conversation that determines whether the prescription covers the dangerous window or the safe one, is not a revenue event. Hit subscribe right now if you believe every American senior on blood pressure medication deserves the timing conversation their prescription label omits. Only the people who are completely comfortable with a system that prescribes the medication without the instruction manual will scroll past without engaging. Everyone else, subscribe, like, and share this video right now. The practical timing guide, what to do based on your pattern, specific and practical. For seniors who are confirmed dippers and are currently taking medication in the morning, discuss with your physician whether evening dosing of your specific medication is appropriate. The benefit is likely greatest for ACE inhibitors and ARBs, which have shorter half-lives and more pronounced timing-dependent pressure coverage patterns. Amlodipine, with its long half-life, may not show a significant timing effect. Your physician can review the specific data for your drug. For seniors who are non-dippers, evening medication timing is supported by the strongest evidence for cardiovascular benefit. The goal is to improve the nocturnal dip that your blood pressure rhythm is failing to produce on its own. A physician-supervised switch to evening dosing, monitored with follow-up home blood pressure readings at 3 to 4 a.m., is the appropriate pathway. For seniors who are overdippers, morning medication timing may be preferable to prevent further amplification of an already excessive nighttime pressure drop. If cognitive symptoms have been emerging alongside a long history of blood pressure treatment, the overdipper pattern warrants investigation as a contributing mechanism. For seniors on multiple blood pressure medications with different half-lives, the timing question is more complex and warrants a specific conversation with the cardiologist or clinical pharmacologist who can review the complete regimen. Splitting dosing, morning for one medication, evening for another, is a legitimate strategy that some hypertension specialists employ to achieve optimal 24-hour coverage. One universal principle applies regardless of pattern. Never change the timing of your blood pressure medication without telling your physician. A timing change is a dose timing change. It needs to be monitored with home blood pressure readings for the first 2 to 4 weeks following the adjustment. And the monitoring schedule should include the early morning hours where the change in coverage pattern will be most apparent. Every morning, before breakfast, after breakfast, or sometime around when you remember, you take your blood pressure pill. And until today, you had no idea that when you take it determines whether its peak effect covers the most dangerous window of your cardiovascular day or the safest one, whether it strengthens a protective nocturnal dip or amplifies one that is already too deep, whether it is doing the most good at 3 a.m. when the pre-dawn surge is building, or whether it is at its weakest precisely when you need it most. You now know these things. You know the Hygia trial and its 45% cardiovascular risk reduction from evening dosing. You know the dipper, non-dipper, and overdipper classifications and what each one means for your timing decision. You know the home blood pressure protocol that approximates your circadian pattern before the ambulatory monitor arrives. And you know the exact sentence to take to your appointment. The $32 billion pharmaceutical industry printed "take once daily" on your label. They did not print, "and here's how to find the time that makes once daily mean the most." This channel printed that part. Hit subscribe, because this channel is going to keep filling in the parts the label left out. Hit like, because every engagement pushes this to one more senior who has been taking their blood pressure medication at 7 a.m. for 5 years without knowing whether 7 a.m. is protecting them or leaving them unprotected during the hours that matter most. And share this video right now. Share it with the person in Birmingham whose blood pressure has been managed for years and who has never once had the timing conversation with their physician. With the woman in Jacksonville who takes her Lisinopril in the morning and wakes up every day between 4 and 6 a.m. feeling their heart pounding, at the exact window where their medication is at its weakest. With the man in Houston who has been on Amlodipine and Losartan for 3 years and has recently noticed increasing forgetfulness without anyone checking whether his nighttime blood pressure is dropping too low during sleep. Tell them the medication is right. Tell them the clock position matters. Tell them one conversation with their physician can determine which position is right for them. Give them that conversation. I'm Dr. Eric Berg. Your blood pressure medication is trying to protect you. Make sure it is covering the right hours. I will see you in the next one.